everyone, my name is Rachel. I'm one of the third-year ophthalmology residents, and this is what the consultant ophthalmologist wants to hear from the consulting emergency physician. First, let's start off with what we'd prefer not to hear. I haven't checked the vision, I haven't checked the IOP, I haven't spoken to the patient yet, I haven't looked at the eye. I once got a consult, it seems reflexively, from the trauma unit based on a CT read for orbital fractures. I went to examine the patient, and it was obvious that he had an open globe and a bigger problem. So always take a look at the eye before you consult us. What you should know before consulting us is, can the patient be dilated? We will immediately ask this when you call us. There are only a few contraindications to dilation. Usually it's neuro or neurosurgery needs to track the pupils for some reason if they're intubated, sedated, have a brain bleed. If they're going for a procedure to the OR, those are some things to think about. Can the patient be moved to the eye room? Are they in C-spine precautions? Are they intubated, sedated? Are they altered? Is it just not possible to get them to our slit lamp? And then, do they have any other injuries? History, you guys should be really good at this, but you ask them about age, race, significant past medical history. Race is important to us for African American patients who have high FEMAs. They need to be screened for sickle cell before we can prescribe Diamox. What is the symptom? Are they having vision loss, eye pain, flashes, floaters, or curtains? How long has it been going on? Has it happened before? Is it getting worse or better? What treatments have they tried? Have they seen an eye care provider somewhere else? What past ocular history do they have? Have they had surgeries, lasers, injections, any trauma? Just the basic stuff. And then here are some basic eye exam supplies. The first is a near card, which you can carry in your pocket or print. I know that the emergency department has a actual Snellen chart lined up 20 feet away, which you guys can always use. Any type of pen light. The first is a muscle light. The second is anything you can buy online. The tono pen, which is your best friend or your worst nightmare, depending on how you use it. A blue light, which is helpful for looking for corneal abrasions when you stain the eye with fluoresce. And a pinhole occluder helps eliminate refractive problems with vision. Topical anesthesia, your fluorescein strips, and paper clips. So like every other department has a primary survey, airway, breathing, circulation, disability, we also have our primary survey. A little bit different, but we call them our eye vitals. And every patient should have their vision checked, their pupils checked, and their pressure checked before contacting ophthalmology. And there are some circumstances where we would not recommend getting a pressure check if you think the eye is open. So vision, you test each eye monocularly, which means you cover one eye and test it and then cover the other eye. You can either test at distance, which is a Snellen card at 20 feet, or at near, which is a Snellen card at 14 inches, but always make sure to document which one you tested. Make sure the patient is wearing their own glasses, because that is more helpful than not. Use bright lighting. And you can use the pinhole to see if that makes things better. And then another trick, if you're worried about optic neuritis, is to take any red object and cover the eye and ask them to look at the red object, and does it look the same with the other eye? And if it doesn't, that could be red desaturation. Pupils, you want to check them in a dark room. Are they round? Are they the same size? Do they react to light? Do they react to near? If you ask them to look at your finger, do they dilate? Is there an RAPD? The best way to look for an APD is with the swinging flashlight test. So you, as you can see in the photo, you will shine the light on the right eye, and both eyes should constrict. And if it's normal, you shine it on the left eye, and then both eyes should constrict as well. However, with someone with an APD in the left eye, you shine it in the right eye, they both constrict. You shine it in the left eye, and they dilate. To measure the IOP, you always want to numb the patient first with Paperclip, and then I want you to take that bottle of Paperclip and throw it out. Make sure the patient does not take it. Do not prescribe it to anyone. Paperclip can melt corneas. And then you're going to take your handy-dandy tono pen. It should always have a disposable tip on it. If it doesn't, it won't calibrate and it will become your worst nightmare. So always make sure it has a cover on it at all times, even when you're not using it. Gently tap the pen perpendicular to the apex of the cornea. Not so hard that you're obviously indenting the cornea, but you need to hear what I call happy beeps. And you don't want to push on the globe when you're taking the eye pressure because that can artificially raise it. So what I do is I say, oh, if you're going to help them open the eye, just rest your fingers on the orbital rim. And then the normal IOP ranges from anywhere from 8 to 21. When you can't open the eyelid, you can turn to Paperclip Desmarres, which is a tool that we use to open the eye. Let's see if I can get my video to play. And this is one I made yesterday in clinic. So you can see you could just tuck the little speculum up under the eye and pull up. If you're not comfortable doing this, don't do this. We don't need to cause an iatrogenic open globe. All right. And then to evaluate motility, you want to do compare both eyes to each other. We usually look at how the iris relates to the eyelid if they're looking in different directions. Do they bury their limbus? Does everything look equal? If things look weird, you can always cover one eye and ask them to do it monocularly. But this is important for cases of cranial nerve palsies, other ophthalmoplegia, and this is just a helpful photo. Secondary survey. So this I probably think is the least important in my thoughts for you guys, but it's also probably the most interesting, is actually looking at them on a slit lamp. So the right photo is a diffuse illumination at the slit lamp, and the left is a narrow beam that cuts through, and you can see sort of the cross-section of all of the structures. So you see the eyelid and the eyelashes, the conj and the sclera, the cornea, the AC, the iris, and the lens. Oops, let's go back for a second. So, can you see my mouse? Anyway, the very front white beam on the left photo is the cornea. The space between it is the anterior chamber. That big object is the lens, and you can kind of see how dense that lens is. And then on the other side, you see that they have a little cataract in the center of their lens. All right. And I think I'll be teaching you guys direct ophthalmoscopy a little bit later, but here are just some introductions to the tool itself. There are a few little moving parts, and then on the right, you see the photo of what you should see when you look in the back of the eye. You can see the optic nerve, you'll see the vessels. Hopefully you'll be able to see the fovea. The best way to do it is to find a vessel and sort of trace it back to the optic nerve. And these are just some different light sizes and colors that we can go over a little bit later. So for the physical exam, what can you see with a pen light? Are the pupils reactive? Is one larger than the other? Is there an APD? Is the eyelid swollen shut? Is there ptosis? Is there a dermatomal rash? Is the eye red or injected? Is there hemorrhagic chemosis, which is when the conjunctiva gets swollen with blood. It's very scary when you look at it, but can be indicative of an injury underneath. Is there a lid laceration involving the eyelid margin? Is it medial to the puncta? Are the eye movements full? And then if you're going to look with the slit lamp, are there vesicles on the lids? Is there a cut that you can see? Is there swelling of the conjunctiva or hemorrhagic chemosis of the conjunctiva? Is there a subconjunctival hemorrhage or a foreign body? When you look at the cornea, is it clear? Can you see the iris behind it? Does the cornea stain with fluoresce? Is it Seidel negative? Is there a foreign body that you can see? And then when you're looking at the anterior chamber, is it shallow or deep? So usually the iris is far back from the cornea, but if someone's in angle closure, it moves up, and we call that shallow. Is there a hypopion, which is a layered white blood cells at the bottom of the anterior chamber? Or is there a hyphema, which is a layered RBCs? Is the iris round or is it peaked? When we say peaked, does it look like a teardrop? And then is the lens clear? And these are just some things to think about. I'm not going to hold you accountable for all of these. I will hold you accountable for getting vision and looking at the pupils and getting an IOP. Thank you very much, and always wear eye protection.